just a quick one. So just a quick one about me. I started my career in health and social care as a support worker, and I've moved into different roles within health and social care over the time as well. And at some point, I was working so much that I wasn't seeing my children that much. And so I decided to contribute to knowledge transfer in health and social care. So I got into training, did all the qualifications. And actually, 10 years this year I've been training. So here we are. So the course itself is a awareness of dementia, safeguarding adult and also mental capacity act awareness. So we are not going to go into the full course. So it's a tester, as you know. So we're just going to give you a summary of part of the course, and we're also going to tell you about what's the areas that we are going to be covering when we do the full session. If you're signing up for the full session as well. We only have about an hour for this course, so we will try to make it as interactive as possible. I wouldn't want to be the one just talking at you all the way through the session, so we're trying to get you involved as much as possible. I'm happy for you to ask me questions at any point during the session, and you can put that into the chat box as well, and then we'll help to pick that up, and then we will discuss that as much as possible. So please ask questions. And if you prefer to ask questions at the end of the session, that's fine by me as well. So just take it as you see fit in terms of the questions as well. So um, the aim of this session really is to introduce us to dementia and also safeguarding adult and the Mental Capacity Act as well, where we're going to be looking at what Mental Capacity Act is and also what mental capacity is and what it's not, and the 5 principles of the Mental Capacity Act as well. So the objectives, we will introduce you to dementia. We'll talk about the types of dementia and also the effect, the signs of dementia as well. And we'll talk about safeguarding adults. We'll talk about different types of the types of abuse, where abuse can happen. As part of that, we also discuss some historical cases of abuse. Some are recent and some are happening in the 2000s or thereabout. Yes. So we discuss that as well. And of course, we'll talk about the Mental Capacity Act. So we're going to start with dementia. And the first thing we're going to do is to try to define what dementia is, or to an understanding of what dementia is. And so I'd like to get you involved in this if you can, if you may, please. You can type your replies into the chat box. Seeing that it's only a few of us currently, you can also unmute yourself and speak. At least it's just a few of us. So if you could unmute yourself, that'll be fine. And if you want to type in the chat box as well, that'll be fine as well. So what is our current understanding of what dementia is?
Just to say thank you very much, Gabriella. I'm sending those links out now. I don't know what's happened there, but I'm sending those out. Thank you.
Okay, Alexis, unable to remember things, difficulty making decisions. Okay, yes. Thank you very much for that contribution. Okay, so I'm just going to move on. And if you want to make more loss of memory, language as well, indeed, yes, language, loss of memory, and also, of course, depending on the part of the brain that is affected by the dementia as well, leading to different effect on the person that is living with dementia. Changing sense of self, indeed, yes, that can happen as well. Please keep them coming. Mood changes, yes, thank you very much. Mood changes as well. So what we have listed here are part of the effect of dementia on the person. Okay, we've got more people coming in. Thank you very much. Right. So, frustration, anger as well are part of the effect of dementia on the person as well. Okay, we have more people joining in. Thank you. Okay.
For anyone, if they'd like to pass it on, if they're being emailed, you can send it all through. Put the link in the chat.
Okay.
Thanks, Lawrence.
Right. Okay. So, dementia itself is a term that is used to describe a range of symptoms. And these symptoms are caused by illnesses or damage to the brain. And because dementia is progressive in nature, it leads to progressive decline in multiple areas of the brain function for that particular person. And of course, that will lead to the disruption of that person's life and including affecting them when it comes to activities of daily living, affecting them in a way of forgetfulness as well, memory loss. And so dementia is caused by when the brain is damaged, and that could be as a result of Alzheimer's disease or series of strokes as well. These are some of the contributing factors when it comes to, okay, I've just seen somebody, okay, when it comes to dementia. And because of the progressive nature of dementia, the damage that dementia causes to the brain increases over time, which makes the person or the symptoms for that person to get worse over time. But in that as well, it is important to remember that every person is different. Therefore, the symptoms will progress at different rates for each individual that's living with dementia. And with dementia, currently, there is no cure for dementia. But you have charitable organizations like the Alzheimer's Society that are researching into treatment, and there are certain types of medicines that are available that helps to slow down the onset of certain types of dementia as well. In the last few months, a medication has been discussed called the donanemab, which has been discussed. The company that made that is called Eli and Lilly and Co. And so they found during their clinical research that it helps to reduce clinical decline in a person living with, especially Alzheimer's, early stage Alzheimer's. It helps to reduce clinical decline by 30%, which is great, which can significantly improve the person's quality of life. It is not yet available in the market because the Medicine and Healthcare Product Regulatory Agency, they still need to look into that. And according to the Alzheimer's Society, a result is expected from the Medicines and Healthcare Product Regulatory Agency this year. And before it can get onto the NHS as well, you have the National Institute of Health and Care Excellence that also needs to approve it. And again, another decision is expected in September this year. And so by that time, we'll know if it can get on the NHS, and then eventually it can be available for people who are living with dementia to be able to take that medication and significantly improve their quality of life as well. Okay, so we've talked about what dementia is. Can we also talk about the signs? We've actually put quite a number of them um, in the chart already as to the signs of dementia, memory loss, part of what we've already noted, disorientation, weight loss. They can be prone to falls as well. Incontinence, mood swings, self-neglect, depression, sensory loss. For example, with self-neglect, forgetfulness can lead to the person, for example, not taking their medication, not eating, not looking after their health and well-being, thereby neglecting themselves um, as a result of dementia. And dementia is quite costly as well. So the direct cost of dementia currently to the NHS and also the social care is somewhere in the region of about 25 billion pounds per annum. And that is expected to nearly double to about 47 billion pounds by 2050. That's according to the Alzheimer's Research UK. So it's quite costly, and still looking at maybe trying to find a cure for dementia as well. And statistically, there are about 850,000 people living in the UK with dementia, which is expected to increase to um, a million by 2025, which will be just next year. And of course, by 2050, that is expected to go to 2 million people. And most people, majority of people who are living with dementia are people over the age of 65. And sometimes you'd find people erroneously believing that dementia only affect older people. No. Currently, there are 42,325 younger people who are living with dementia. And that will range from people in their 20s to their 30s who are living with dementia as well. So dementia can almost affect anyone of any age, really. From that point, it can affect, and of course, the effect of that on that individual will be different from somebody who is in their 80s. So a younger person might still have a mortgage to pay off. They might have a younger children, and the effect of that on the family structure as well can be quite significant. Dementia as well is currently the biggest killer in the UK. And so in 2022, it became the leading cause of death with about 967,000 deaths recorded or associated to Alzheimer's and dementia disease that was recorded in England and Wales. And that accounted for around 11.4% of all deaths. Women are more likely to die from dementia. That's because they tend to live longer than men. And because for a person who is living with dementia, especially the later stages of dementia, the person is likely to have a weak immune system, which increases the person's level of risk when it comes to getting infections. And one of the most common cause of death when it comes to infections from dementia is pneumonia. So it increases the risk of the person getting infection, and so um, it increases the number of death as well uh, when it comes to dementia. So with dementia, there are well over 100 types of dementia. There are quite a number of them, but there are four main types of them. And Alzheimer's is the uh, most prevalent when it comes to dementia. And so people know more about Alzheimer's compared to other types of dementia because 60% of people who living with dementia have Alzheimer's disease. And vascular disease is the next, which is about 15%. Then people can also have two types of dementia in one, so they can have mixed dementia. Most commonly, that will be Alzheimer's disease and vascular dementia as well. Then there is dementia with Lewy body, and there is also frontotemporal dementia. And in terms of how that happens, in terms of how, for example, Alzheimer's, that will be as a result of a buildup of plaques in the brain, or they called tangles as well. So they can build up in the brain, and they can lead to the loss of connections between the nerve cells. And when that happens, it will eventually lead to the death of those nerve cells and brain tissues. Vascular dementia, for example, is as a result of diseased blood vessels. So what happens is that these diseased blood vessels, they reduce the blood supply to the brain. And as a result of that, vascular dementia comes in. This type of dementia can also be stroke related as well. But I won't get into too much as to how they come by, because that will be in the main session. Also, we only have about an hour for this session, so I don't want to spend too much time on this. I want to be sure that we can cover everything that we need to cover. So apart from the prevalence when it comes to the prevalence rate for dementia, there are risk factors as well. The likes of age will be a risk factor, lifestyle, like alcohol, smoking, drug and diet as well, and learning disability, mental health, generic disability, diabetes, Parkinson's as well as some of the other risk factors as well. Now, in itself, they're not causes of dementia, but they are the risk factors. These are factors that contribute to the risk of a person having dementia. And as for the diagnosis, when it comes to dementia, the mini mental state examination, that is the most commonly used test for dementia. But there are also blood test can also be used, MRI scan as well, EEG, CT scan, PET scan can all be used to diagnose dementia as well. And currently there's a new blood test that is quite accurate. And so moving forward, that is what is going to, I believe, is going to be used mostly for to diagnose for dementia, because it's quite accurate in its result and for dementia. Okay, so I would leave the topic of dementia here, because we've talked about what it is, we've talked about some of the signs, we've talked about prevalence as well. Do we have a question in the box?
Yes, we do have a question from Gabrielle. Is that generic, or is it genetic? Sorry.
Right.
When we're talking about dementia, is that what you mean, Gabby? Yeah, the last slide.
Right. Right. So that was a
good
typo,
question,
yeah.
Actually. Yeah.
Yeah.
Is it genetic?
Yeah, it is genetic. That was a typo.
Okay. Yeah.
Thank you. Thank you for picking that up.
Thank you.
Okay, so if we move on, and just a quick one on what we will be looking at during the full session, if you're joining us for the full session. And as part of that, we'll talk more in terms of different types of dementia, and talk about their impact as well. We'll talk about the psychological needs of people who are living with dementia, and also the medical and social model for dementia as well, because the difference between the medical and social model for dementia, the medical model for dementia is heavily focused on the condition itself, and the social model is more holistic. It's person-centered. It looks at the condition and also the person as a person, and also helps looking at supporting the person to utilize the skills that they have retained. And so it is more holistic in the way we look at the person as well. So we'll talk about this during the full session. We'll talk about the person-centered approach as well. Dementia will affect people in different ways, and everyone is different. So how best can we support people with their dementia in their own unique way? So we focus on the uniqueness when it comes to person-centered as well. And of course, dementia support, including activities, how to support them with daily, everyday activities of daily living. And so those are the areas that we are also going to look at as part of the full session for dementia. But before I move on, I'd like to ask if there is any questions that that anybody want to ask before we move on to safeguarding of adults.
I have a question. It's Alexis.
Okay, Alexis.
Sorry, it might seem like a stupid question, but what's the main difference between dementia and Alzheimer's disease? Because I always get confused. I thought they were basically both the same, but you said at the start that dementia's not. So I just wanted to clarify the difference.
Okay. So it's like you have a tree and you have branches. So dementia is the tree, and then you have different branches. So Alzheimer's is one of the branches. Vascular dementia is one of the branches. Frontotemporal dementia is one of the branches. Dementia with Lewy body is one of the branches.
Okay, that makes sense.
Yeah, so because dementia itself is caused by different things. So Alzheimer's dementia is caused by Alzheimer's disease. Vascular dementia is caused by difficulty with the vascular system of the body. And so really, in a nutshell, it's the tree and you have the branches.
Okay, that makes sense. Thank you.
Okay, you're welcome. Any other questions? Okay. If you do have questions, like I said before, you can still put them in the chat box, or you can unmute yourself now or at the end of the session. So if we move on to the next part, which is safeguarding adults, and if we start by talking about what safeguarding is, and at this point, if you could please get involved, you can type in the chat box or unmute yourself as well. And if we just quickly discuss what safeguarding is, then we'll get into other part of this as well.
Not to be confused with my area, which is child safeguarding, which is for under 18s. But we're talking specifically about over 18s, aren't we?
Over 18s.
So
yes.
yeah, adult safeguarding, people's current understanding of that.
Okay, Lorena. Mary, your mic is off.
Oh, yes. I just say it's just the same as the others, reporting risks to individuals, keeping them safe, empowering them. Yeah, that kind of thing, just how to best protect people.
Indeed.
Yeah.
Indeed. Thank you very much, Mary. Lorena said, when you protect a citizen's well-being. Okay, yes. When you protect people's well-being. Okay, thank you very much. So okay, we've got another question. Protecting vulnerable adults. Indeed, yes, protecting people who are at risk of abuse. So the way the Care Quality Commission defined safeguarding, just as about how you've defined it as well, protecting people's health, protecting their well-being and human right as well, and where we are enabling them to live free from harm and abuse. And for them, especially in the care sector, they also mentioned that it is fundamental to high quality health and social care. So the way I put that is care is holistic. So we're not just focusing on the supporting people with their activities of daily living. We're also ensuring that we're protecting them from being abused by people who might want to take advantage of the person's dependent on other people as well. With safeguarding, it encompasses 6 principles, and the principles will include empowerment, it will include prevention, proportionality, protection, accountability, and also partnership as well. Now, these principles are put in place to prevent abuse from happening in the first place, and also to be able to respond to it appropriately in cases when abuse eventually happens. And so safeguarding is everyone's responsibility. We all have a responsibility when it comes to safeguarding people. And of course, you mentioned around reporting as well. So, how would you define abuse? What is abuse to you? Okay. Verbal abuse, yes, that's a type of abuse. Thank you very much. Exploitation, yes, in different ways, financially, sexually, and many other ways as well. Yes. Yes, abuse of finances, either by a random person or any person with a duty of care to support the person, harming someone mentally or emotionally. Indeed, yes. Thank you very much. Okay, so in terms of how abuse is defined as well, you've said it all. So really, any act of maltreatment by a person or persons that violates another person's human and civil right, and that will cover what you've already mentioned in the chat box. And so people can be violated or maltreated in different ways by a person or different persons, and this can happen almost everywhere. If you recently, about a month ago or 2 months ago, there was a case in the news around people who were abusing people that they were meant to be supporting in a care setting, and some of them have been sentenced to prison as well. Now, uh, in terms of abuse, it's where people misuse the power that they have over another person. If people need care and support, then the person who is caring for them and supporting them, or if people are at a risk of abuse, other people who are that way inclined can take advantage of that. And by doing that, they would have been abusing the person. And so we used to say vulnerable adults, but in 2014, the Care Act of 2014, where you have the care certificate defines an adult who is at risk of abuse as someone who is in need of care and support, as someone who is either experiencing abuse or at risk of experiencing abuse, and where they are unable to protect themselves. So if the person is in need of care and support, now when it comes to the care and support as well, it doesn't matter who is providing it. that could be from a paid carer, it could be from a family member or a neighbor. It doesn't really matter as long as they are in need of care and support. And they are either at risk of abuse or experiencing it and neglect as well, and they are unable to protect themselves. So that person will be considered as an adult who is at risk of abuse. So we used to say vulnerable adult. Now we say adult at risk of abuse. But if you look at it really, every one of us is vulnerable to something at some point. But then there are people who are at risk of abuse as a result of their needs, as a result of other people having access to them and supporting them, or they are dependent on other people as well. And with abuse, any type of abuse is abuse. It doesn't matter if it's intentional or if it's not, if it's unintentional. As long as it's abuse, it's abuse. But of course, the principles of safeguarding will come into that, in the sense that proportionality, which is one of the principles. So how abuse is responded to then matters. Yes, yes. As long as you have those needs and then you are at risk of abuse because of those needs, and you are also unable to defend yourself, then you will be considered as an adult who is at risk of abuse because of those needs. Thank you. Right. As for the adults who are at risk of abuse, you are looking at people with, sorry, there's another message in there. Well, so that's another part of it. If you've not been assessed for uh, the needs, then that is different. But if you've been assessed for those needs and you've been identified as one who needs the support, and you have the other factors that are present as to if you're unable to defend yourself, if you're at risk of abuse happening to you because of those needs as well, then that adult will be an adult who is at risk of abuse. Does that make sense, Gabriel? Exactly. Exactly. It is important to get those needs, the needs assessment. Okay. So for adults who are at risk of abuse, we're looking at adults with learning disabilities, for example, adults with physical disabilities. It could be sensory disabilities as well, people with mental ill health as well, and it could be adults who are frail due to their age as well, or adults who are living with dementia as well. And so you have different set of adults who will be in that category as to adults who are at risk of abuse. So we've talked about what abuse is, or safeguarding is, abuse, and also adults at risk of abuse. Now, where can abuse happen? You can type your replies into the chat box, or you can unmute yourself as well. In the home, definitely. Anywhere, indeed. Yes, you're right. Anywhere. In the home, in fact, majority of abuse that happens in people's own homes. And it's not coincidence that most of the least number of abuse happens in hospitals. And that is because there are other people around and they can see. And so people do not really, well, there are other types of abuse that happens specifically when it comes to hospitals. But in terms of people taking advantage of finances and physical abuse and psychological and these other ones, most of it will happen in people's own homes. So indeed, you're right, Gabriel. Abuse can happen anywhere and everywhere. In people's homes, in hospitals, at a day center, at work as well, in the community as well, at a social club, anywhere really, as you put it. So abuse can happen, which means that we all have to contribute to safeguarding people, because abuse can happen everywhere and anywhere. So, for example, in the workplace, it might be difficult to um, consider any of our colleagues as someone who can abuse other people, but it does happen, and people can do that as well. So, if we move on to who might be the abuser, we know abuse can happen anywhere. So, who might then be the abuser? Who can abuse?
Friends, family, well, anyone really. Anyone,
Yes,
people care, staff, their own family, partners, friends. There's institutional abuse. And yeah.
yes, yes. Anyone and everyone can abuse. In fact, research has shown that majority of people or majority of abusers are people known and trusted by the adults. And that includes family members, carers, workers, just as you've mentioned as well. And, and some people will deliberately abuse adults who they see as easy targets as well. And um, no one would really like to think that a colleague could be abusing an adult, but it does happen. And there are some historic cases. If you remember the case of Harold Shipman, the GP, who will go into people's homes and they will be the last person to see them, and then he will inject them with high dosage of morphine, and then they'll die, where most of it was done just because it felt like he had the power to take lives, and it was the last person that he killed that exposed him, Catherine Grundy, and he was going to benefit to the tune of £387,000 thereabout. He doctored the lady's will, and so you then have family members who were questioning what had happened. Meanwhile, the funeral directors within the area were also suspicious because a lot of people were dying from his surgery as well. And eventually uh, he was sentenced to life imprisonment for the death of about 11 people, but the police suspected that his death, he would have killed up to about 200 people, and eventually he died through suicide in in jail. So that was somebody that was trusted. He was meant to be looking after people and getting them better and relieving their pain, but he wasn't doing that. And in a care setting, there was a one in 2011. If you remember the Winterbourne View case, it was on Panorama. And you mentioned organizational abuse as well. That would be a classic case of organizational abuse, because in the Winterbourne View case, one of the senior nurses reported to management that abuse was taking place, and they just ignored it. It went to the directors of the organization, nothing changed. In fact, this person said they went to CQC, yet nothing changed. Indeed, religious institutions, indeed, and individuals, yeah, religious institutions as well. So nothing changed in this case until this person went to Panorama, the BBC program, and they sent a guy called Joy Casey to go and get a job there, and he went with a camera and recorded everything, the horrific abuse that happened in the place as well. Without him exposing the abuse, people would have just been abused, and the organization would have just turned a blind eye and just moved on from there as well. And more recently, if you remember the case of the police officer Wayne Cousins, who killed Sarah Everard as well. So these are people that you expect people to trust. A police officer, you see a police officer, you think, yeah, they are here for our safety. not knowing that this particular person had their own plans. So really, it will be people that people can trust. It will be people. In fact, studies shows that when it comes to financial abuse, adult children are the leading perpetrators when it comes to abusing older people, with especially older people when it comes to financially as well. Of course, religious institutions, you'd have that happening in different forms as well when it comes to abusing adults as well. Um, in terms of the number of abuse that we have, there are 10 types of those abuse types. Of course, you then have subtypes under these types of abuse. So you'd have the likes of psychological abuse, discriminatory, self-neglect, organizational. Organizational abuse is also called institutional abuse. Then you have neglect, physical, domestic, sexual, financial, and also modern slavery as well. And so that's been added to over the time. There was a time we had 6. There was a time we had 8, then eventually 10 currently that we have. The likes of modern slavery and domestic abuse, those two were added around 2015. You'd expect that more will be added to it over the years, but currently we have the 10 types of abuse. And in terms of reporting abuse, there are barriers to people reporting abuse. And what we want in order to be able to prevent abuse from happening, at least from stopping it when it happens, is for people to be able to report it. But unfortunately, there are barriers to reporting abuse. Sometimes people will fail to recognize that what is happening to them is actually abuse. And sometimes it's a case of where they'll feel that they will not be believed. I remember in 2017, I was in a place called Clacton-on-Sea in Essex, delivering safeguarding course. And I think I had about 6 or 7, one man, one gentleman, and the others were ladies. Of the 6 ladies, 3 of them were sexually abused when they were younger. And none of them had mentioned it. None. None. And when I asked why, the answer was they wouldn't have believed me. They wouldn't have believed. In fact, I think one of the ladies, that was the first time she was mentioning it. Others mentioned it later, but at the time that it happened, they couldn't because they felt like they wouldn't be believed. And so that is also another barrier. And you'd expect, in terms of fear of reprisals, you would expect that when you depend on people for your activities of daily living and you're fearful of what they can do to you if you report abuse, including within the organization as well, where people are thinking, oh, I can't mention this because that can affect my job. But of course, every organization that employs 5 or more people should have policies in place, and whistleblowing policy should be part of what's in place so that people will feel confident to report cases of abuse as well. And the 5th point talks about breach of confidentiality. In terms of reporting abuse, that's one of those times where we'll have to set confidentiality aside and we can report. And now, sometimes when people hear confidentiality, the first thing that comes to mind is about keeping secrets. No, confidentiality in this case is not about keeping secret. Confidentiality is about information on a need-to-know basis. So if it relates to the person's health and safety and well-being as well, if it's going to impact negatively on that, then we should be reporting. So if we're working for an organization, they should have they should have a policy on that. And so we should be following the guidelines for our specific organizations when it comes to reporting abuse when that happens as well. Sometimes people are not sure that their concerns are valid. So there are so many barriers as well to reporting abuse, and we'll discuss this more in details when we get to the main session as well. And just lastly, During the full session, we're going to be talking about safeguarding legislations. And as part of that, we'll talk about health and safety and other legislations that are relevant as well, including the CARE Act from 2014 and the responsibilities that, when it comes to safeguarding, that local authorities now have when it comes to safeguarding. To talk about principles of safeguarding in details. We get more into the types of abuse, indicators of abuse as well. So what we're going to look at during the full session is talk about the abuse, and we talk about the types. We'll also talk about the signs to indicate to us that abuse could be taking place. The risk factors are part of what we're going to talk about as well. And we'll talk about factors that will enhance reporting. What are those factors that will make it easier for us to be able to report, and the responsibilities that we have when it comes to reporting and recording abuse as well. Okay, so just like we did for dementia, just a quick one. If you do have questions, you can put that in the chat box, or any observations, you can do that as well. And when we finish that, and then we'll just quickly look over the Mental Capacity Act.
Gave lots of case studies there, Lawrence. I think you explained that really well. Thank you.
Thank you. Thank you. Okay, so let's get into the Mental Capacity Act. The Mental Capacity Act is a law from 2005, and it applies to people who are age 16 and over, and it explains how to balance empowerment of the people and to make their own decisions. Of course, that's what we want. People needs to be able to make their own decisions, and wherever it's possible, and also protection of people who lack the capacity when it comes to making the decisions by themselves as well. And the last point talks about how it applies to people from age of 16, but it only enables people from the age of 18 or over to plan ahead of a possible loss of capacity in the future, so they can make advanced plans, including advanced refusal for support, and also the likes of DNR, do not resuscitate, and other plans that people might want to put in place. So the Mental Capacity Act itself came into force in England and Wales in 2007, although it's a law that came in place in 2000, well, it came into force in 2007, and where it makes it possible for individuals, as I mentioned, to plan ahead, to make arrangements about the care that they would like to receive, for example, about their finances, where they can also have people with lasting power of attorney. And so where they can have a lasting power of attorney as well from there. And the Mental Capacity Act, so if we start from what mental capacity is, mental capacity is about our ability to do four things, really. It's about our ability to understand information that we have been given. It is also about our ability to retain that information long enough for us to be able to make a decision from it. Now, in terms of retaining the information, we don't have to be able to retain all of the information, as long as we retain enough for us to be able to make a decision from it. Then where we have capacity in that sense. It's also about our ability to understand the risk involved, or the consequences of the information that we have been given, and also the ability to be able to communicate our decisions. Now, if we are unable to do any of this, then we may be assessed as lacking capacity. So what mental capacity does not mean is that the person is very old, or they have a condition that affects their ability, or they are a bit different in their lifestyle. No, it doesn't mean that. neither does it. It does mean that a person may lack capacity for particular decisions, because sometimes people will have the capacity to make certain decisions and they will lack the capacity to make other decisions. And so that's where the mental capacity assessment will come in, to be able to identify the capacity level and what they have capacity for, and the areas where they might be lacking in capacity to make decisions from that. And as part of the Mental Capacity Act, there are 5 principles. The principles of the Mental Capacity Act begins with the presumption of capacity, where we have to assume that people have capacity. And the good thing about it is that if we assume that people have capacity, it means we have to be person-centered in our relationship with them, in our encounter with them, which means we have to put them right at the center of our interactions with them, of whatever we do to support them if they lack capacity. So we have to it's the mental capacity assessment that will identify if they have capacity or otherwise. Well, we just don't conclude that people lack capacity until the assessment is done. And the second principle talks about how there is a need for us to enable the person to make a decision by, for example, giving them the opportunity using their preferred method of communication. So if their preferred method of communication is through marketing and they have hearing impairment, for example, and we've asked them a question verbally and they are unable to reply, we cannot turn around and say they lack capacity to make decisions because we have not used their preferred method of communication. So we are expected to try everything before we can be having doubts about their ability to make decisions. And the third principle of mental capacity is about unwise or eccentric decisions, meaning that people have the right to make decisions that others might look at and say, oh, that's unwise. Now, as long as they understand the consequences of their decisions, just like for everyone else, we have the right to make decisions that we deem fit for ourselves, as long as we understand what the consequences are. For example, Jehovah's Witnesses, I believe, they do not take blood transfusion. And so if they need blood transfusion and they understand the consequences of their decisions, then it's left to them to either accept that or not, because they understand the consequences of it. The fourth principle of the Mental Capacity Act talks about the need to ensure that whatever decisions that we are making for people or on behalf of individuals is in their best interest. Because after they've been assessed as lacking capacity, there might be decisions that we have to make for them or on their behalf. In doing so, we have to ensure that the decisions we are making is in their best interest. And lastly, we also have to ensure that the purpose is achieved in a way that is not going to restrict that person, especially of their liberty. So it's not going to be restrictive. And that also stretches into another legislation called DOLS, Deprivation of Liberty Safeguards. Okay, right. Okay, so it's just 1 minute past 11 now, and we're nearly there. If you could please just give us a few more minutes. I know your time is precious and you have so much to do. Please bear with us for a few more minutes and then we will round this off shortly.
Our apologies, we started a bit late, started about 5 minutes late. So yeah, thanks, Lawrence.
Thank you. Right, so So that's the last principle of the mental capacity, at least restrictive decisions, and that leads to another legislation, which is an extension of the mental capacity Act called DOLS. Over the years, from 2022, it's meant to have changed to liberty protection safeguards, but that's going to be coming into effect shortly as well. So during the main session, we're going to talk about when a capacity assessment is necessary. We talk about consent as well, the two steps of the capacity assessment. We go into the prevention of liberty safeguard as well, and also how people can use the Mental Capacity Act to plan ahead as well during the main session.